Okay, in this section, we're going to go over vascular pathophysiology. And this is actually really important because we're going to discuss how changes in vascular pathophysiology relate to clinical symptoms and how it also impacts laboratory tests. So, when we look at the big picture, we went over the introduction to cardiovascular disease, and now we're on vascular pathophysiology. Now, the academic goal of this presentation is to understand the pathophysiology of endothelial injury in atherosclerosis development. And the clinical objective of this presentation is to understand which specific laboratory biomarkers are involved with the pathophysiology of atherosclerosis development. So these are the main topics that I want to go over, starting with review of the vascular system. And when you look at the vascular system, you basically have blood vessels. With blood vessels, you have the microvasculature, which are the arteries and veins, and carries blood, to organs in a way, to and from tissues. And then you have the microvascular arteries, like arterioles, and they're innervated by sympathetic pathways with vasoconstriction. Arterioles play a major role in tuning vascular resistance and blood volume necessary for capillary fluid exchange. And you have the capillaries, and this is where all the main exchange takes place. Capillary and venules are the main sites of fluid and macromolecule exchange. And the capillaries also, we have leukocyte adhesions, and the venules that are involved with the capillaries as well. So here you can see, the typical vascular system, oxygenated blood in red, and then you can see the cardiopulmonary circuit in between here, and you see the capillaries where the exchange takes place, and then the blood flow going back throughout the veins. And then when you look at the arteries and veins, one of the things just to pay particular attention to is that both arteries and veins have these vascular endotheliums, and then the arteries obviously having musculature. I don't know if you guys remember human anatomy, but I always remember it was always hard to tell which was artery and vein because they had the same color. You had to actually squeeze them. The ones that had resistance were the arteries, and the ones that had no resistance were the veins. But here you can also see the vascular endothelial cells, whether you're looking at arterioles or venules or arteries, that they all have this thin vascular endothelium around them. Then you can see the different types of capillaries. Here's the capillary bed where the exchange takes place, at tissues, and then blood returns back into the vein pathways there. Then you can see the valves that are so important to allow blood to return to the heart that can get injured with chronic venous insufficiency. Then when you look at the total amounts of blood reserves, we can see that 84% of the blood is in systemic circulation, of which 13% is in the arteries, systemic arteries, and 9% in the pulmonary circulation. The heart has 7%. But in the veins themselves, we have 64% of our blood itself. So when you look at the total structure of all these arteries, veins, capillaries, venules, they all make up the vascular endothelium, that this thin layer of cells around all of them are involved. So the vascular endothelium is a thin layer of simple squamous cells lining the entire surface of the cardiovascular system from the large arteries and veins to the small capillaries. Now, the vascular endothelium is an endocrine gland. The vascular endothelium are cells, and they release things like vascular endothelial growth factor. They release things like nitric oxide. So when we look at our arterial system, it's not just these pipes that are just carrying blood back and forth, that there's some endocrine signaling dynamics that are important. And then these endothelial cells are really critical for maintaining our functions. So here you see the slide, and it's titled Endothelial Cells, the Vascular System. It says the vascular endothelium, thin layer of squamous cell lining surface of the vascular system, the boundary between circulating blood vessels and underlying tissue. And then you can see that the vessel's wall consists of endothelial cells, muscle fibers, and elastic fibers, and endothelial cells constitute the entire blood vessel wall, all the different structures. And then the endothelium, once again. And again, this is where everything happens. This is what we're trying to preserve in a functional medicine model. This is a preventive medicine for cardiovascular disease, to keep these cells as healthy as possible and make sure that they're not injured. And they're all throughout the system, both in arteries and in veins. And now when you look at the vascular endothelium and these epithelial cells, these endothelial cells, it's just like the gut. They have to have tight junctions. And if these vascular endothelial cells, these epithelial cells start to open up, then you can get a whole series of events that take place that then lead to atherosclerosis. And when you look at the vascular endothelium, and you look at these, studies or these valuations, look at this total surface area of the vascular endothelium. The vascular endothelium makes up 14,000 square feet of surface, or 6.5 tennis courts. So This is the vascular endothelium. All these cells that are then releasing growth factors and things like nitric oxide and have major influences on uh, vasodilation, inflammation, platelet activity, immune responsiveness. So they're critical to keep healthy. So I think the main takeaway, once again, is um, it's not just blood vessels that get plaque. It's blood vessels that have cells that are critical for health, and these cells get destroyed. And eventually, if they're destroyed, the aftermath of that is they're patched up with all this plaque. But keeping as many of these cells healthy is ideal. So let's say you had severe injury to the vascular endothelium and you only had half the tennis courts available for your neuroendocrine immune system to function. There's no doubt you'd be chronically sick. Even if you lost part of your vascular endothelial cells, your chance for maintaining homeostasis and staying healthy are a problem. So, that's the key thing that I wanted to go over the first part of this review of the vascular system. Isn't really what arteries and veins do. It's that stop thinking of arteries and veins as just pipes. And these arteries and veins actually contain cells, and these cells are highly functional cells. And these cells are not really classified as part of the endocrine system because they release different growth factors and they have receptor sites for them. And they play a major role in cellular communication and immune function and controlling proper transport of different cells across the body. Now, let's go over the specific functions of the vascular endothelium. So we know it's everywhere. It's all throughout, 6.5 tennis courts full of these cells. So these endothelial cells primarily have three functions. They stimulate vascular branching. They're involved with barrier function of transport of glucose and lipids or transendothelial transports. And they regulate metabolic homeostasis, and this is where the endocrine function comes in. Let's go over the first part, which is they stimulate vascular branching. By vascular branching, this is also referred to vasculogenesis, angiogenesis, arteriogenesis. And really what that means is our arteries have to branch. So in order for our tissues to heal, in order for us to stay healthy, blood vessels have to branch out into different tissues, and the more efficiently they can branch out into different tissues and throughout our organ system, the healthier that our body stays, and healthier it becomes. So remember, oxygen is carrying all of our nutrients, all our hormones, all our signaling agents, all our immune cells, and we have to have this constant branching of our blood vessels throughout our body and our tissues to maintain our health. So here you can see the diagram illustrating like angiogenesis that's taking place. These vascular endothelial cells are releasing growth factors and different mediators, then allows these branches to take place. So one of the things that happens when people start to injure their vascular endothelium, maybe like for chronically high hypertension, like a smoker who has oxidative stress to their arteries and there's all this free radical circulating his arteries because they smoke all day. And they also have high blood pressure. And then the blood pressure, that injury just damages those cells. They end up over time really damaging these endothelial cells. And then once these endothelials are injured, there's inability to activate things like vascular endothelial growth factor. And vascular endothelial growth factor is responsible for shaping the structure of the cells to then sprout out. So then we can have connectivity and function and get nutrients and tissues to other areas. When this doesn't take place, people lose the ability to recover. This is like one of the things you'll see with vascular endothelial injuries, foot ulcers that don't heal. People have peripheral arterial disease, they have foot ulcers that don't heal. People that have vascular endothelial injury in their blood vessel in the brain, they get microvascular strokes, little silent strokes, but they can't get new branches of blood flow to those areas because these cells are compromised. So these endothelial cells release things like vascular endothelial growth factor, VEGF, angiopotens, ANG1, ANG2, nitric oxide, plasminogen activators, semaphorins, and then these are then signaling agents that increase vascular branching. The vascular branching enhances tissue healing, improves insulin sensitivity, enhances hormone impact, and enhances immune function. So in order to get your hormones into your tissues, in order to get your blood flow to your tissues, your glucose to your tissues, in order to get fuel and energy to your tissues, get immune cells to your tissues, you have to have this constant endothelial function happening all the time. So when someone is saying like, hey, my nail beds are white now, my toenails have this fungal overgrowth, my feet are cold all the time, my blood pressure is starting to go up, they're basically saying is their endothelial cells are dysfunctioning. And they're also telling me that they are losing some degree of vascular branching. And if you look at studies where they look at injuries, here's an injury. This is a mouse study. You can see the tail. Um, and they look at ischemia models when they injure it. In order for the leg to recover after a crush injury, it all has to do with these branches taking place. So one of the other signs of a person that has poor endothelial function is that they don't heal from injuries. So whether it's a sprained ankle, they just don't heal as quickly as they used to. Where there's a crush injury, like you see here, where there's someone tears something in their limb or wherever the ligament or situation is, the inability to recover and heal is one of the red flags of endothelial dysfunction. And part of that has to do with this vascular angiogenesis pathway here. So this is just an image that just shows these endothelial progenitor cells that then activate vasculogenesis and arteriogenesis, and these capillary beds start to mature, and then all the immune cells and immune functions can then go through. We know that when you look at different diseases where there's decreased angiogenesis because of endothelial dysfunctions, these are associated with Alzheimer's disease. It's part of the pathophysiology of, for sure, vascular dementia. And we'll see it in conditions like Crohn's and celiac disease, and people that have chronic skin disorders, people that have their skin not heal, people that have inflammatory reactions in their tissues that just aren't healing. Those are partly due sometimes to endothelial dysfunction. And then these signaling factors in endothelial cells that release this, there's a huge list of what all of those are. If you want, you can review these papers. And most of the papers that I go through in the course materials you have in your, most of the papers I go through in the PowerPoints you have in your course materials. So if you see a topic or a chart or something that looks like it's very interesting to you, you can go and read the full paper. And there's also many drugs that are used that activate the angiogenesis pathways, like treatments for foot ulcer medications are important, and even some medications that are there to help with infections and recovery really involve activating endothelial cells to release these growth factors that then allow this blood formation to take place. And these vascular endothelium cells are turned on or turned off by different types of cellular messenger pathways that take place. But the bottom line is they're a function, vascular branching is a function of these endothelial cells. This is so critical for us to maintain them. Now, if you see a person that has like nails that are all beat up and they just look unhealthy, that's usually due to lack of blood flow. Like that's when you know the nitric oxide system is down. When you see nail beds that look unhealthy, remember when someone's wearing a shoe, they're sweating all the time, so they get fungus. But normally immune cells that are get to the distal toes avoid that fungal overgrowth in their nails. So when you see fungal overgrowth, it's a sign of poor circulation. But when things get a lot worse is when you see leg ulcers that don't heal. You're going to see that with peripheral arterial disease all the time. Okay, and when people get older, sometimes they may get like a cut in their face or cut in their upper facial areas, and they just are not healing. It takes forever for it to heal. It's not related to diabetes. It's just that they can't get that vascular branching that's taking place. And that's a huge red flag that their vascular endothelial cells have been severely compromised, and that they may even have some degree of vascular disease that's occurring that you may want to definitely jump into and figure out what's happening there. Now, this other function of these endothelial cells is involved which is called the endothelial transport. And things like fatty acids and lipoproteins and lipoprotein lipases and glucose and insulin have to cross these vascular endothelial cells. And just like in the gastrointestinal tract, the gut, we have things like occludin and zonulin and collagen proteins. The same thing takes place in the vascular endothelium. So there's tight junctions, and there's paracellular pathways where they go through the cell, or transcellular, they go across into the cells. And these pathways are there to get white blood cells and glucose and fatty acids and other compounds through. And when you look at the transcellular pathway, things like glucose and fatty acids and insulin and long-chain fatty acids, they all have to get through the vascular endothelium to then supply heart tissue, cardiomyocytes, and skeletal muscle and adipose tissue. They all require fuel sources and nutrients and so forth. And these cellular messenger responses allow the transport of these compounds to go through, as well as white blood cells to go through. And these are all involved with the transcellular pathways. So you can see these tight junctions open up, and these things can then cross into the cell. Now, when you look at the vascular endothelium, these tight junctions can be injured. And this actually is what starts the whole process of atherosclerosis. So, people in functional medicine love intestinal permeability, leaky gut. It's something that they're very familiar with, something they look at all the time. So it's really the same things happening in some sense with diseases of the vascular system. And there's first this permeability that causes these tight junctions to break and open that then lead to chronic inflammation. And this is specific for the vascular system as well. And then you can see vascular permeability images here, normal blood vessel, some acute inflammation. You start to see some little cracks against these barriers, chronic inflammation, get significant inflammation. There's lots of inflammation in the arteries like cancer. You can see significant breakdown and changes of those tight junction proteins. And here you can see an illustration of a nice, healthy vascular endothelial tight junction. And then you can see one that's compromised and broken down with an electron microscope. And then here's another image of like stable tight junctions. And then this is what breaks. Once these breaks, that's when lipid particles can come in and start infiltrating in the vascular endothelium. This is why smaller sized particles are a bigger risk factor, because smaller sized particles can accumulate through this leaky vascular barrier that they can then cause that accumulation of fats that they can oxidize, that then lead into atherosclerosis. Now, things that cause vascular endothelium permeability, it's just like the gut. It's inflammation. So chemical factors, if there's more inflammatory cytokines, free radicals, bradykinin, histamines, than there are things like antioxidants, vascular endothelial growth factor, and nitric oxide, then you get vascular endothelial permeability. And then blood pressure. There's increased blood pressure because there's lack of nitric oxide or too much stress hormones like epinephrine, norepinephrine, or too much sodium retention or not enough magnesium or potassium, and that causes the blood pressure to go up. That can then start to damage the barriers and you get permeability. So, blood pressure elevations, hypertension does cause vascular endothelium permeability. So it's like this inflammatory cascade, this mechanical pressure then starts to destroy the vascular barrier system. And that vascular barrier system is an important part of function to allow glucose and lipids, insulin to cross at a regulated rate. So there's efficient fuel delivery to different cells like cardiomyocytes and so forth. And then the third function of these endothelial cells is to regulate metabolic homeostasis. And this is where the endocrine function comes in. These endothelial cells release metabolites like nitric oxide and intracellular matrix proteins, growth factors, and cellular enzymes. And this was, a really nice summary of all these pathways here. And, the simple fact is that the endothelium is an endocrine organ. And these endothelial cells have an impact on inflammation and white blood cell trafficking, angiogenesis, overall metabolism, and they can impact the vascular tone, they impact coagulation. So they play a really important role. And these vascular endothelial cells are really important because they really help with one of the most important releases, which is nitric oxide. And what releases nitric oxide is increased blood flow. So, for example, when someone works out and exercises, that causes the release of that stimulates these vascular endothelial cells to release nitric oxide. This is also why you feel really good after your exercise. That, you sometimes look at your skin looks healthy, it's all this blood flow, you have all this blood flow in your muscles, your body feels like it's recovering, you have lots of energy, you feel really light. A lot of that is happening because as you increase your heart rate, you get increased flow and throughout your arteries, and this increased flow across the arteries stimulates blood vessels to then release nitric oxide, and that causes that vasodilating effect. And here you can see increased blood flow activates these nitric oxide receptors, These endothelial cells then produce nitric oxide. And this is one of the key things that really not only helps with vasodilation, but protects the vascular endothelium. So the more active you are activating nitric oxide, the healthier the vascular endothelium becomes. Now, in order to make nitric oxide, you have to have precursors, and the precursors are from dietary sources, arginine, but even more important, you need to have nitrates. And what happens is that when you ingest vegetables and fruits, for example, you can see this image here, beets and different vegetables, the nitrates in these foods get metabolized by oral bacteria. Here's the different bacteria in the mouth that start to metabolize nitrates in foods into nitric oxide. And then these provide a precursor nitrite source that then is used to make nitric oxide. And then we know that some of these pathways also take place in the stomach as well. And studies have shown that people who use mouthwash all the time have reduced nitric oxide levels. People that are on protein pump inhibitors have reduced nitric oxide levels. So if you have someone who's eating well and they're eating lots of vegetables and fruits, but they're overusing their mouthwash or just even using mouthwash on a regular basis, it's going to destroy the bacteria species they need to make nitric oxide. So there's protein pump inhibitors, and they don't have that acidity required to activate this nitrate to nitrite process that's involved, and their plasma nitric oxide levels can be a factor. So that's something to be aware of as well. Here's another illustration of the same thing. They're showing dietary nitrates, and the bacteria in the mouth convert them to nitrites, and the bacteria in the gut convert them to nitrites, which are then maintained in the vascular endothelium. And then when you get blood flow and circulation, that turns on the messengers to activate endothelial nitric oxide synthase, and the nitric oxide is released, and then we have vascular protection. It's a combination of the things we eat and stimulation to these receptors in the endothelium that then causes release like nitric oxide. Now, if you look at the endothelial cells themselves and look at how it plays a role as the endocrine system, there's receptor sites for everything on these endothelial cells. These endothelial cells have receptor sites for insulin, estrogen, progesterone, thyroid hormones, inflammatory mediators, and then immune modulator, immune signaling systems, vasoconstrictors, platelet aggregate, signaling agents. These are all, these receptors are found all throughout the vascular endothelium. And this is why things like hormone imbalances and thyroid hormones cause significant disruption in these vascular endothelial cells, which we'll get into later when we talk about the web of vascular disease. So you can see things that have a apoptotic or pro-apoptotic, anti-apoptotic effect with these different mediators that involve vascular endothelium. Things like VEGF and antioxidants and things like estrogens, they all seem to have some degree of protection. And then things like advanced glycation end products, oxidized or glycosylated LDL inflammatory mediators start to have this destructive process on these endothelial cells. So these endothelial cells are critical, that they really are involved with major function to keep us healthy. And once they get injured, we have a problem. So let's now move on to what happens when these vascular endothelial cells get injured. What are the clinical symptoms? What are the early presentations when those things start to occur? So here you can see an illustration. On the left-hand side, you have what's called a healthy endothelium. On the right-hand side, you see what's called dysfunctional endothelium. And basically, it's an inflammatory response that's occurring in these tissues. So in healthy endothelium, there's reduced reactive oxygen species. There's lots of circulating antioxidants. There's lots of circulating nitric oxide, lots of healthy nitric oxide release, which has an antioxidant protective response. So everything is maintained. There's no injury to the blood vessels. Everything is fine. With a dysfunctional endothelium, one of the key features is there's either too much inflammation or not enough antioxidants to quench it. Remember, the main antioxidant for blood vessels is nitric oxide. And once this destructive process starts to take place, then, you see this analogy here called the cytokine tsunami, that the endothelial cells, instead of releasing things like nitric oxide, they themselves start to increase production of inflammatory mediators. And then these inflammatory mediators start to impact tissue. There's less vasodilation, so you start to see signs of poor circulation throughout the body, and these blood vessels are starting to get injured. And this is then going to cause permeability of these blood vessels and set up the stage for dysfunction. So you can look at this in kind of like two ways. One is, in order to keep blood vessels healthy, you have to, one, reduce things that destroy it, and two, have lots of antioxidants there. And the main antioxidant that's there is these nitric oxide outputs that these endothelial cells themselves put out. And when these endothelial cells get injured, they then just shift into this inflammatory tsunami, this vicious cascade that then perpetuates itself and creates this feed-forward process that we're going to go into. And then here you can see damage to these cells. Healthy cells that easily comes in and repairs it. Everything's fine. You have angiogenesis, but unhealthy cells, that's a major problem. Now, if we summarize differences between healthy and dysfunctional endothelial cells, these are the main differences. So let's talk about healthy endothelium. First of all, there's vasodilation. That's one of the key things versus less vasodilation. You guys see vasodilation? You can see it on people. You can see people that just, their skin is glowing. They look healthy. Their nail beds are pink, right? Versus someone who comes in and their skin is like aged and unhealthy and like dry, and their nail beds are totally white and blue. So that's one of the immediate things you can physically see it on a visual inspection. A healthy vasodilation versus lack of vasodilation, right? And in healthy endotheliums, you have increased endothelial nitric oxide synthase activity. And when you look at nitric oxide has an enzyme called nitric oxide synthase. And nitric oxide synthase is found in blood vessels as endothelial nitric oxide synthase, and that's what we're focused on. There's also NNOS, which is neuronal nitric oxide synthase, and that's found in the brain. And precursors like nitrates can activate neuronal nitric oxide synthase, and that activates neuron synaptic activity and neuron signaling and neuron branching, and there's lots of great things with neurons. There's also another enzyme for nitric oxide, which is INOS. And I stands for cytokine-inducible nitric oxide synthase. That's found on immune cells, and that turns on this inflammatory oxidative destructive process that immune cells need to destroy pathogens. So when you look at nitric oxide, if the ENOS pathway is being activated, the endothelial nitric oxide enzyme is being activated, that's going to cause all these beneficial effects we're talking about. If the neuronal nitric oxide synthase is being activated, that's when you have synaptic activity and great function. And when the INOS pathway is being activated, that's when you have immune activation for inflammatory destructive processes. But our focus in this course is this ENOS pathway, this endothelial nitric oxide synthase pathways, which blood flow and circulation and getting your heart rate up have an impact on. Now, that's one of the key features of a healthy endothelium, is these endothelial nitric oxide synthase pathways are active and responsive, and in dysfunctional epitheliums, the endothelial nitric oxide synthase pathways are low. Antioxidants are higher in healthy endotheliums versus dysfunctional epitheliums. Anti-inflammatory prostaglandins are higher in healthy endotheliums than unhealthy endotheliums. And your prostaglandin is going to be just largely influenced by your diet. So healthy fats are going to increase your anti-inflammatory prostaglandins, and then unhealthy fats like fried fats and even foods that are high in arachidonic acid can increase these inflammatory prostaglandins. There's less reactive oxygen species and healthy, more reactive oxygen species and unhealthy. There's decreased thrombosis activity in healthy versus increased activity in dysfunctional epitheliums. And then when they actually measure the inflammatory cytokine content of healthy endotheliums versus dysfunctional, there's a difference. So literally, if you look at all the dynamics that are taking place between a healthy and dysfunctional pattern, it's almost opposite of each other. And the healthy endothelium, you have improved tissue recovery, enhanced muscle and brain endurance, and this reduces the risk for cardiovascular disease and neurodegenerative diseases, and also for all-cause mortality. And when people have their dysfunctional endothelium, they have slow recovery from exercise. It's another major feature of the dysfunctional endothelium. Poor muscle and brain endurance, exaggerated inflammatory responses, and this increases the risk for these patterns. This may be something else you see as well. When people start to have the endothelial dysfunction go down, they stop moving. And part of the reason they stop moving is they go to exercise and they don't recover. And even when they exercise, they get more pain and more inflammation afterwards. And they just go, I feel awful. And a lot of this may be attributed to the oxidative inflammatory process that's taking place in these blood vessels. You get people that, or another response is people keep getting injured over and over again. There's a point like if they work out, if they try to work out 2 or 3 days in a row, they just get an injury. And that injury takes a long time to heal. Those are all signs of endothelial dysfunctions. And they're really trending on this dysfunctional side. Now, what's very interesting is when these endothelial cells are dysfunctional and these inflammatory mediators are up, when they look at studies like allergens, like here's a scratch of something and then coming into the system, could be exposure to air antigens, or it could be dietary protein antigens. But when the blood vessels are activated and inflamed, there's lots of immune responses going there, the allergen response, the inflammatory response from the antigen is exaggerated, which is really, really interesting. Because when people have dysfunctional vascular endotheliums, they may have a much more severe reaction to their allergy or to their food sensitivity. And that's another key thing that you'll see with these endothelial dysfunctions. So here you can see like dietary protein reactivity, pathogens, free radical chemicals, tissue injury, they get exposed to the vascular system. If there's already pre-existing inflammatory mediators in the vascular endothelium, because these vascular endothelial cells are unhealthy and they don't have enough nitric oxide to keep them protected and to keep the inflammation down, then things like dietary proteins can cause exaggerated inflammatory responses. And same with chemicals and even with tissue injuries. This can lead to complications from infections, exaggerated responses to food sensitivities and allergies, exaggerated response to airborne chemicals, antigens, and pollutants, impaired recovery from tissue injury. And you'll see in clinical histories people that start to work out and exercise, and they'll say, oh, their food sensitivity reactions are much, much less. They're not reacting as much to things like they used to, or their allergies are improved. And you go, well, what's happening there? It's not necessarily that their leaky gut's being fixed. A lot of times it's just that the inflammatory mediators in the blood vessels are going down. So once again, healthy nitric oxide activity has an effect on modulating the pre-existing inflammatory state in these blood vessels, which then different antigens can activate and trigger. So that more inflammation that is pre-existing in the blood vessels before an antigen exposure, the greater the response. So that's the key thing here. This is just a diagram. It's a paper you have in your course materials. It just shows all the different diseases and expressions of vascular endothelial development, injury, and so forth. That it's not just atherosclerosis. And then what I want to show you next is really like the progression of vascular injury, right? So first of all, there's reduced activation of endothelial mediators. Like ENOS goes down and VEGF goes down. Like endothelial nitric oxide synthase will go down just for being sedentary. So if you have someone who's just not moving, not activating these endothelial nitric oxide receptors, because they're not getting the heart rate up and moving around, and then things like free radicals, oxidative stress can decrease ENOS. And then if these endothelial cells are not being activated, these endothelial nitric oxide synthase are not being activated, things like VEGF1 also goes down. And this is like reduced activated endothelial mediators that's there, right? And again, you can see this. You see people that have signs of poor circulation, poor blood flow. When we talk about doing a vascular exam, we're going to go into what all those presentations are clinically. But basically, it just looks like a person that does not have good circulation and good blood flow, right? Someone with bloodshot eyes and ruptures and hair falling out and unhealthy skin and poor nail beds, touch their feet, it's freezing and it's cold. Those are endothelial mediators that are not in a healthy state. So once there's reduced activation of endothelial mediators, this leads to susceptibility for injury. And then you get vascular endothelial permeability. Just like you get leaky gut, you can get leaky vascular endothelial patterns as well. This vascular endothelium permeability causes injury to the vascular epithelial cells itself. Now there's this cytokine storm causing injury all around this vascular area. And then this causes a replacement of these epithelial cells. Then it's by atheromas, by atherosclerosis. So when plaques take place, that's a permanent injury of these epithelial cells. It's just like, think of the tennis court analogy. We had 6.5 tennis courts surface area of epithelial cells. You just put patches of plaque all over those. Those are cells that are gone forever. They're not coming back, right? They're just injured. Even if the plaquing can go away with different mechanisms that can occur, those endothelial cells are injured. They're not coming back. Then over time, as we lose our endothelial cells and get more into atheroma, we get a feed-forward cycle. We get vascular diseases. And then things like stroke and heart attacks and TIAs and venous insufficiencies and vascular dementias and peripheral arterial diseases come up. So there's this cascade downward that we want to look at. And we really need to find these things in the really early stages with endothelial mediator dysfunction before they get down here, because once they get down here, there's some significant injury to these epithelial cells themselves. Now, part of the process of this pathophysiology is that it's a feed-forward process, that things accelerate really, really quickly. So let me put it to you in a clinical context. By the time someone starts to show, for example, signs of peripheral arterial disease and their legs, like let's say it took 30, 40, or 50 years, they start to have signs of changes in blood pressure between arms and legs, their ankle-brachial index is off, their pulse rate's going down, they're not getting good blood flow to the legs, they're cramping up all the time. The next year you see them, it's going to be much, much more progressed. And the next year you see them, it'll even be faster progression. So the progression goes fast. Once it turns on and you see it, it goes fast. It's not going to go at the same pace. The progression's always going to be faster. So once you see peripheral arterial disease, the progression is going to be faster in the next year. And then following year, it's going to be even faster than that. That's because these are feed-forward cycles. And in a clinical setting, if you can keep them where they are, you're actually doing a great job. So if you can prevent this feed-forward system to take place. So here you can see one of the mechanisms, which is the hypertension feed-forward cycle. So there's high blood pressure that causes injury to the epithelium. Injured epithelium then can't produce nitric oxide. Then there's less vasodilation. Then there's more blood pressure. And then this injury to the epithelium causes atherosclerosis. Now you get permanent loss of these injuries. Now you get narrowing of the arteries, which then causes more changes in pressure. So you have more blood pressure. Now you have this vascular endothelium dysfunction. And guys, there are people that will get to the point where their blood pressure is not going to respond to anything nutraceutical. There's so much rigidity and stiffness and plaquing in their arteries that you're not going to be able to incorporate a nutraceutical model or even a lifestyle model that's going to change. And this is the people that you'll see in your practice that are on one blood pressure medication to the next class of medication, to the next class of medication, to the next class of medication, and they still come in with hypertensive disease. That's significant vascular epithelium injury. Now, another feed-forward cycle is when you have increased vascular endothelium permeability from the inflammatory free radical process that causes vascular inflammation. Then that vascular inflammation, that's that cytokine tsunami that then breaks down more tight junctions. And then you get this inflammatory response from the permeability feeding more permeability, and you get this feed-forward cycle there. This is another part of it. So the injury to the vascular endothelium promotes more injury to its surrounding tissues. This is why you have to immediately quench inflammation and use high amounts of antioxidants and look at markers like oxidase LDL and get those under control as soon as possible because you have to stop these feed-forward processes. Or say it differently, once vascular disease pops up its face clinically, however that expresses, maybe it's chronic venous insufficiency, maybe it's peripheral arterial disease, maybe it's angina, it's going to go really, really fast. And you really have to be very aggressive with it and manage it. And this is why you may even have to consider downstream approaches in certain cases, even if you're really medicine, pharmacology's last resort. It really depends on the severity and the seriousness and the speed of these things. But there is this feed-forward cycle phenomenon of vascular disease. And then you have atherosclerosis feed-forward cycle. So atherosclerosis causes decreased endothelial cells. The less endothelial cells, there's decreased protective growth factors and vasodilators. There's more endothelial cell injury, not enough recovery, and this whole perpetual cycle promotes itself. So these are the feed-forward cycle mechanisms that take place. So you have to immediately quench inflammation. You have to immediately decrease blood pressure. You have to immediately increase antioxidants to really break this cycle and this pattern. Because if you don't, the progression will just accelerate and speed up and speed up and speed up with time. And then here's the vicious cycle where the bottom line is endothelial cells get dysfunctional. You get decreased nitric oxide. Then you see things like blood pressure and blood flow dynamics go off. Now, nitric oxide levels going down is really the hallmark of vascular pathophysiology. Like that's it. That's the main marker. It's also the main marker that then leads to vascular diseases. So nitric oxide is involved with many things. So here's the breakdown and summary of the functions. So it dilates blood vessels and modulates blood pressure. It protects the vascular endothelium. It dissolves atherosclerotic plaque. There's engorgement of the penis for erection. There's engorgement of the clitoris for orgasm. It activates immune activity. Promotes blood flow for tissue healing. Stimulates neurotransmitter activity in blood vessels and in the brain and throughout the body. Protects the gastric epithelium and modulates mitochondrial biogenesis. And these things increase energy, tissue recovery, healthy circulation, brain function, and optimize sexual function as well. So when nitric oxide levels go down, you get a set of symptoms that take place. So endothelial dysfunction, and before you get progression of vascular disease, you have people that start to complain of decreased muscle stamina. People say, I can't work out, can't recover like I used to. That is decreased nitric oxide. We're all going to lose some nitric oxide activity as we get older. And as we get older, we're not going to be able to recover and work out like we used to. So, you're going to feel different at 50 than you do at 60. Yeah. And that's partly because our endothelial cell function goes down with age, right? And I'll show you some illustrations of that. You just want to maintain as much of it as you can for the longest period of time. So in addition to decreased muscle stamina, there's decreased brain endurance, there's decreased sexual stamina. Erectile dysfunction in men is another common scenario. Sexual arousal disorders in women has been linked to nitric oxide, where they just don't get any pleasure from sexual activity. Elevations in blood pressure, poor circulation, hands and feet, inability to adapt to high altitudes, delayed tissue recovery, and general fatigue. Now, I want to talk about blood pressure for a second. People are sometimes confused with nitric oxide. Nitric oxide is a modulator. So if you have low blood pressure, that doesn't mean you have too much nitric oxide. Actually, if you have low blood pressure, it means you might have low nitric oxide. Because nitric oxide, again, modulates, right? It modulates. So nitric oxide helps with vasodilation, right? So people that have low blood pressure, they also have really, really bad circulation. And that low blood pressure doesn't allow that blood flow to activate receptors throughout the system. So you need some pressure to push blood against your vascular endothelium. If you have too much pressure, you start to injure the vascular endothelium. So you need to have normal blood pressure to get enough pressure to stimulate the endothelial nitric oxide receptors from blood flow. And people that have hypotension can't do that very well, so they have low nitric oxide. And then people that are hypertensive start to damage these tissues as well. So low nitric oxide is found with both low blood pressure and high blood pressure patterns as well. But when the endothelial cells start to dysfunction and before you get full-blown vascular disease, these are the clinical symptoms that will show up first. So here's an illustration of that: normal vascular health, endothelial dysfunction, symptoms of nitric oxide, levels that are low, like we just went over. So there's vascular injury happening here. And then somewhere from the symptoms of low nitric oxide over the next 10 to 30 years when atherosclerosis and vascular disease pops up. So as a clinician, you want to look for these early symptoms as much as possible in a preventive medicine model and try to do things to optimize that. And here you can see, like, for example, the timeline progression of stroke. Someone has no vascular injury, everything's fine. 40 is when they really start to have their vascular endothelium levels start to go down. Vascular endothelial function start to go down. And then as their vascular endothelial function goes down, they get more vascular injury. And then boom, by 60, they have a stroke. These are the feed-forward cycles that really speed everything up at a certain point. Then when you look at research on aging and nitric oxide levels, age 40 is where things start to decline. And by age 50, there's a 50% decline in nitric oxide. And by age 70, there's a 75% decline. And this is attributed to, like, wait till you're 50, you're going to see how you feel. Wait till you're 70, you're going to see how you feel. Versus those that are saying, hey, I'm 50 and I've never felt better. I'm 70 and I can't wait to get outside and go for a run or do something, and they're physically active. So age isn't the only variable, but as we age, we have more insults to our vascular endothelium, and over time we get more injury. And on the average with people today, 50% of nitric oxide levels go down by age 50. But for some people, it's not 50%. Some people, it's 10%. Some people, it's it's no change. So it all depends on what's impacting their uh, vascular endothelium health. And this is in reference to the vascular age. So there's biological age and there's vascular age. So they're not the same. So let's talk about these. So biological age is just how old you are, right? Your vascular age is how your blood vessels compare to someone else. So you could be 50 and have a vascular age of age 30, and you still have healthy circulation and blood flow and so forth. Or you could be 30 and have a vascular age of someone who's 50. You've had increased vascular injury. So if you look at the biological age and the vascular age is greater, then that's early vascular disease. That's where you have progressive arterial stiffness and loss of arterial elasticity and compliance and altered vascular smooth muscles and calcium deposit in the vascular wall, and that's when the vascular age goes up. So if the biological age is greater than the vascular age, then there's no vascular disease. That's what everyone's shooting for. If the biological age is equal to the vascular age, then over some time you do get some late onset vascular disease. Like even if your biological age and vascular age are equal, by the time you're 80, 90, you may have some atherosclerosis that shows up. Doesn't mean you'll have a stroke or a heart attack. You just have some identifiable atherosclerosis. But the main issue is people have usually higher vascular age and biological age. And these have been also mapped out by looking at a coronary calcium score. So if your coronary calcium score is 20, you have a vascular age of someone who is 61, right? And you can see plenty of 40-year-old people that have a coronary artery score of someone who's 20. If you have a coronary artery score, and let's say you're 50 years old, you go get a coronary artery calcium score, and it's like, let's say a little bit over 1,000. Then the person has a vascular age of someone who's 89. So you can look at these charts and understand biological age versus vascular age. It all has to do with how healthy these endothelial cells are coming along. And you can see different publications and studies kind of looking at these vascular health. And vascular health has to do with the amount of plaquing that's there and the amount of endothelial function that's there. Remember, the more plaquing you have, the less vascular endothelial cells you have that are still functioning. They're injured. And over time, these nitric oxide levels can decline to some degree. So you got to keep these endothelial cells healthy so you can keep as much nitric oxide. If you don't, this vicious cycle takes place. These are the different mechanisms summarized for you in a chart that decrease nitric oxide. So just aging and moving around and doing things, sedentary lifestyle, lots of oxidation, they decrease endothelial nitric oxide synthase activity, so it's easier to have nitric oxide levels go down. Things like oxidation of LDL, systemic inflammation, vascular autoimmunity damage the endothelial cells directly that produce nitric oxide, so nitric oxide levels can go down. And then excess free radicals, lack of antioxidants, they cause free radical scavenging of nitric oxide, and nitric oxide levels go down. So not only do free radicals damage the vascular endothelium, but even if there was some release of nitric oxide, free radicals go ahead and basically scavenge and use them up as a free radical. So then the nitric oxide can't have its protective effects on surrounding tissues. So there's a direct effect on actual nitric oxide with free radicals, in addition to the injury to the vascular endothelium. And then things like mouthwash, heavy antibiotics, protein pump inhibitors, they reduce nitrate to nitrite precursor availability for endothelial nitric oxide in the blood vessels to use to make nitric oxide, so the nitric oxide levels go down. So if you take someone who's sedentary, you get someone who's got systemic inflammation because they have an H. pylori infection that's asymptomatic, they haven't identified, and they use mouthwash every day, and then there are protein pump inhibitors. You can see some major mechanisms that decrease nitric oxide that may not be, looked at. And if that happens for 5 years, 10 years, 15 years, and then like 50, they go and get a coronary calcium score, and they may have a calcium score of 400, and now they have a vascular age of 83. So those are the mechanisms that I want you to understand about this topic of vascular endothelium dysfunction. And then diabetes and high insulin, high glucose, inflammatory cytokines. Not only do they injure the vascular endothelium, but they actually shut down the enzyme endothelial nitric oxide synthase, which decreases nitric oxide. So even if someone doesn't have an abnormal coronary artery calcium score, there's no atherosclerosis, there is still suppression of the enzyme uh, endothelial nitric oxide synthase that's used to make nitric oxide that can be hindered, leading to then increased risk for vascular disease because of the nitric oxide levels dropping. Okay, so that's the impact of vascular endothelial dysfunction. That's important for you to know. Now we're going to talk about the progression of these things and then how this leads to hypertension and how this leads to atherosclerosis. So let's talk about hypertension because this is really important. Now, you have to measure your patient's blood pressure when they come in. You got to know what it is. And if it's abnormal, you have to monitor it. So this is really, really important. I mean, some people just do blood pressure screening as part of a routine exam. They even do it. They have staff do it. And they just kind of look at the number and ignore and look at the chart and kind of do what they want to do, right? But if someone has hypertension, it's a big deal because hypertension means they are having direct mechanical injury to the vascular endothelium. And the higher their blood pressure, the more destruction you have. And these hypertensive destructive pathways that take place on the vascular endothelium cause a fast feed-forward cycle. Over time, it gets much, much worse. So you really want to catch it and address it as soon as possible. Now, when you look at hypertension, 90 to 95% of it is primary or essential hypertension. And that can be from things like not enough, like too much sodium in their diet, not enough potassium, sedentary lifestyle, obesity, hyperinsulinemia, chronic stress, susceptible genes, and basically all these mechanisms change the dynamics of pressure, and it may even impact endothelial destruction on another variable altogether. And then you have 5 to 10% that have hypertension secondary to, like, they have kidney disease or they have pulmonary disease or they have hyperactivity or an adrenal tumor. But it's really this primary essential pathway that we want to look at. And 50% of hypertensive patients are unaware of their condition and have ongoing vascular damage or increased blood pressure. And, question again to you. When was the last time you checked your blood pressure? What is it? If it's high, you're getting injury to your endothelium. And you put it this way. If it's high, let's say you're 40 and it's high and you're getting injury to your endothelium, by the time you're 50, you've had some significant degree of destruction. So now you're 50 and go, 50 sucks. I can't do anything. I can't recover. Yeah. And then 50 to 60 is going to be much worse, much faster. Versus you were 40, you caught your blood pressure was high, you managed it. What happens between 40 and 50 is you preserve more endothelial cells. So now 50 isn't as bad as the other person. This is why it's so important to keep an eye on blood pressure and see what those levels are. And it's, hypertension, the silent killer. And it really is true. And as the vascular endothelium gets destroyed, you get plaquing, and then the higher the blood pressure, the more chance you have to have emboli, break off and have embolytic stroke or some other kind of embolytic complication. So when you look at blood pressure is this balance. Fundamentally, what's happening in the vascular endothelium is this balance between vascular endothelium nitric oxide pathways that protect and dilate the arteries versus the renin-angiotensin system pathways that constrict the arteries and are impacted by stress, salt, potassium, and magnesium. They're also influenced by pulmonary and renal functions, especially the secondary types. And if you have someone who has greater angiotensin II, they're also at more risk for constriction, prothrombic activity, pro-inflammatory activity, pro-oxidant activity, all the things that lead to vascular disease. And the nitric oxide pathways are there for dilation and anti-clotting mechanisms, anti-inflammation pathways, antioxidant pathways. And then things like exercise and nitrates from vegetables and flavonoids help keep this system healthy. And then things like too much stress and too much salt, not enough potassium, not enough magnesium, not enough calcium can really promote this angiotensin system pathways as well. And when you look at this balance between nitric oxide activity, angiotensin system, and hypertension, if you look at the statistics, 1 out of 3 people in the US have hypertension, which means in your practice, you should be diagnosing it all the time. Hypertension is the number 1 modifiable risk factor for developing CVD. This is not even questionable. It is the number 1 factor. And also for just thinking of healthy aging and longevity. So we're on module 10. Module 12, we're doing a whole module on longevity medicine. And a huge part of that is maintaining your vascular endothelium. And one of the main ways to maintain vascular endothelium is to make sure you don't have hypertension. And hypertension is also the number one risk factor for CVD mortality, that if you do have an event, will you die or not? Now, when you look at the nitric oxide pathway, we kind of explain how it works. You take nitrates from food, convert it to nitrites. That takes place in the mouth, that takes place in the gut, and that stores in your vascular endothelium. Blood flow and circulation activate the endothelial nitric oxide system, release nitric oxide, and it keeps your blood pressure healthy. Now, the angiotensin system is a little bit different. What happens with the angiotensin system is the liver produces angiotensin, and then things like drops in blood pressure, drops in blood volume, normally in a normal circumstance, cause renin release from the kidneys, and then renin acts on angiotensin to form it to angiotensin 1. Then angiotensin 1 is impacted by the angiotensin converting enzyme ACE from the liver, which then ACE acts on the angiotensin 1 to convert to angiotensin 2. And then angiotensin 2 has two pathways, one of which angiotensin 2 acts directly on blood vessels, stimulating vasoconstriction and narrowing. And then angiotensin 2 stimulates and acts on the adrenal glands to release aldosterone. Aldosterone acts on the kidneys to reabsorb and retain sodium. And these things then cause the blood vessel constriction and causes blood pressure to go up. And it's this dynamic between kidney function, adrenal function, lung function, hypothalamic signaling that's all controlling this angiotensin system. And then when you look at all the different mediators of blood pressure, this is why you have, beta-androgenetic antagonist and A1 antagonist and calcium channel blockers and vasodilators. They're trying to block every different parts of the system. But again, these are more downstream effects. We want to look at upstream effects. So stress itself is without question an activator of this angiotensin system. Stress activates the adrenal glands. Adrenal gland activation activates angiotensin. You get aldosterone, you get sodium retention. High salt in the diet contributes to this. And there's some recent studies that show that once the glomeruli in the kidneys get inflamed, they become much, much more sensitive to high sodium in the diet. So inflammation in the glomeruli is one of the main reasons people become more sodium sensitive as they get older. So it's like when you're like 30 or 40, you can have lots of salt and not even notice anything. But when you're older, especially as the glomeruli in your kidneys start to get inflamed and injury, salt can have a huge impact on your blood pressure pretty quickly. So that's something to be aware of. So sodium retention then causes increase in change in the blood vessel pressure, hypertension, and stress responses, increased vasoconstriction. You get hypertension in those mechanisms as well. So here you can see different things that increase hypertension. So we're going to talk about some of these more when we talk about the vascular physiology and the web that's involved with it. But body fat tissue, increased stress, sympathetic activity are all key factors that can impact hypertension. Ultimately, there's an inflammatory malt model, there's insulin resistance that's involved, and there's sodium retention that's involved. Now, calcium is critical to maintaining blood pressure. This is an illustration of what happens when there's not enough calcium intake. So if there's not enough calcium intake, calcium modulates many of these renin and angiotensin pathways and these receptors that then lead to increased blood pressure. And sodium and potassium also have a significant role in these angiotensin systems. So too much sodium or not enough potassium. And because a lot of people are potassium deficient and people are not getting enough potassium. And when you look at manufacturers are making potassium supplements with like less than 100 milligrams, and people need 2,000 to 3,000 milligrams of potassium as an ideal dose. So they have to take high amounts of potassium. Sometimes you have to take potassium bicarbonate to really get blood pressure down. You need to get a powder form so you can get that 1 gram, 2 gram, 3 gram level potassium to really make a difference. Taking like a capsule of potassium from a nutraceutical isn't going to be enough. And there was some studies years ago where people had renal disease and they took high amounts of potassium. They got some complications, and then they made all manufacturers limit their potassium intake. I believe it's like less than 90 milligrams per capsule. But in people that don't have kidney disease, in order to get blood pressure down, you need to use gram loads of potassium and limit sodium. And then magnesium has also been shown to play a huge role in different mechanisms that not only control blood pressure, but they also impact inflammation, oxidative stress of the arteries themselves. And over time, as people get blood pressure, the higher their blood pressure, the more injury they get to their blood vessels. And as blood vessels get injured over a period of time, they also remodel and actually change their anatomy and change their structure, which then can lead to chronic patterns of hypertension and endothelial dysfunction. So you got to get blood pressure under control as soon as possible. And one of the things we'll talk about clinically is people where you can't get their blood pressure down. And there is a point of so much stiffness and rigidity in blood vessels that even with exercise and gram levels of potassium and complete sodium restriction and magnesium and endothelial nitric oxide stimulators like vinpocetine and ginkgo and hawthorn, you can't get their blood pressure down because there's too much injury there. There's not enough vascular endothelial viability. So time is of the essence. You have to get these under control as soon as possible. Now, let's talk about cholesterol metabolism. So we talked about blood pressure. We know that as the vascular endothelium gets injured, there's less nitric oxide release. And then if you take nitric oxide release, that's low. High salt intake, and then deficiency of potassium and magnesium can increase blood pressure pretty significantly. And stress response increase blood pressure. And that's the hypertensive model of heart disease. Okay. What I want to talk about is the atherosclerosis process, which blood pressure contributes because it does injure the vascular endothelium. But before I can talk about the atherosclerosis pathway involved with developing plaques and thrombi and emboli, let's go over cholesterol metabolism first. This will be important to understand because it also will help you understand what VLDL is and LDL is and HDL is and apoprotein A is, apoprotein B is, and so forth. These will be lab markers that we're going to look at. Now, remember, we need cholesterol, we need fats, that our cells have to use cholesterol for building blocks, for cellular repair, for cell structures. We need cholesterol for hormones, and we need fatty acids for fuel. So we have to get, fat from our diet, and our liver has to metabolize and process fat and fatty acids, and then transport that tissue, transport those fats throughout our tissues, and that's where these lipoproteins like HDL and LDL come in. So here's just a step-by-step approach of normal transport and usage of lipoproteins. So I'm going to go through it one by one just to make sure it's really clear. So cells need fatty acids for fuel and cholesterol for raw materials. The liver produces something called VLDL, right? A very low density lipoprotein. And this is made up of a protein called ApoB protein, cholesterol, fatty acids, and phospholipids. The combination of these have an impact on density, and density is very low. These are called very low density lipoproteins. This is released into circulation. Then as VLDL is circulating, it loses triglycerides and becomes IDL, intermediate, right? Lipoprotein, and then it contributes, or intermediate density lipoprotein. Then IDL contributes to loss of triglycerides and then eventually becomes LDL. And the triglycerides are released into circulation, are used by fuel, or the fatty acids are released, right? Or the phospholipids are released. So think of the liver, think of these apoprotein B as like a transporter. And the liver is putting all this phospholipids and fatty acids all on top of it, and then it's going to release it. And think of like a card going down the pathway being this ApoB protein, and all the things are starting to fall off. So as these lipoproteins go throughout circulation, those fatty acids start falling off. Those fatty acids are then in the bloodstream and they're used by cells for fuel. And this is the normal process. And eventually the VLDL size changes, and as most of these phospholipids and fatty acids start to fall off, as it goes into circulation, you get a low-density lipoprotein, and then that low-density lipoprotein can then bind to an LDL receptor. And the goal of the LDL binding to receptors so it can transport cholesterol into it. So LDL binds to LDL receptor on the cell. LDL is transferred into the cell, and ApoB protein is cleaved off, and free cholesterol is used for the cell. And then some LDL breaks down into free cholesterol into circulation. And then free cholesterol binds to ApoA protein and becomes HDL. So HDL is the ApoA protein. And HDL transport cholesterol back to the liver. So that's the normal response. Liver makes VLDL, which is apoprotein B, cholesterol, free fatty acids, and phospholipids. That goes through circulation. These fatty acids, phospholipids start to fall off over time in circulation. You're left with LDL. LDL can then bind to a receptor on a cell, and then cholesterol is then carried into the cell. Then some of that cholesterol that's still in circulation and the LDL breaks off, and then ApoA protein binds to it, which now becomes HDL. This is why they call LDL sometimes bad cholesterol, HDL good, because the more cholesterol hanging around in circulation, the more risk there's for plaquing. It's a very simplified model. So LDL is basically the ApoB protein bound with cholesterol and fatty acid and phospholipids, and HDL is the ApoA protein that's bound with some free cholesterol. So this is normal function. This is how we transport lipid proteins. Now, let's talk about what happens when things are going the wrong way. Abnormal transport and usage of lipoproteins. So LDL in circulation is oxidized by free radicals into oxidized LDL. This is where things are going wrong. So instead of getting into the cell, before it gets into the cell, releases cholesterol, LDL is oxidized. Oxidized LDL is changed structurally and unable to bind to LDL receptors and deliver cholesterol into the cell. So now it can't do anything. It's just oxidized LDL. Can't bind to receptor, can't transport the cholesterol into cells anymore. Its structure has changed from free radicals attacking it and destroying it. Oxidized LDL and free radicals in circulation damage the vascular endothelium and make it permeable. So you get this leaky blood vessel. Circulating LDL, especially small particle LDL, diffuses into the leaky vascular endothelium and becomes trapped. That's why this is a big emphasis on small particle LDL. Trapped LDL within the cell wall is now oxidized, and macrophages produce foam cells to initiate the atherosclerotic process. So circulating LDL can be oxidized, and once LDL gets trapped, especially small particles within the vascular wall, there's inflammation there, so they get oxidized as well. And that's the pathological process. Now, if we go back to normal function, which is here, let me illustrate that for you in a diagram. So when we look at normal function of how cholesterol transport works, we eat foods, dietary lipids, gallbladder releases bile. Bile helps break down bile acids, help convert dietary lipids into these chylomicrons, these free fatty acid stuck compounds. And then the free fatty acids, these chylomicrons that are attached to the free fatty acids, eventually get used in circulation at some point, but also these remnants of them get to the liver. And once these fatty acids and cholesterol compounds go into the liver will then make VLDL. Here's very large density cholesterol. As it transports through the bloodstream, fatty acids and phospholipids fall off. So you get intermediate density lipoprotein that eventually, over time, as it's transporting the blood circulation, more of the free fatty acids and phospholipids drop off. Then you get LDL, and then LDL cholesterol can bind to a receptor, getting that tissue have an effect. And at some point, the free cholesterol from the LDL binds to the ApoA protein, and then it gets back into the liver as HDL. That's what the whole HDL, LDL, VLDL is all about. Now, when you look at, let's go back here. Here is the LDL cholesterol. You can see it being taken up. So remember, the VLDL has lots of fatty acids, phospholipids. Those start to break off. Then you have cholesterol. They get this cholesterol that needs to get into the cell. The LDL cholesterol binds to the LDL receptor. Cholesterol gets taken into the cell, and it's used for biosynthesis. Maybe it's producing estrogen, maybe it's producing testosterone, whatever is needed from that cholesterol. You can see the HMG reductase pathway turning it on. And then if there's no need for cholesterol biosynthesis within the cell, there's this SREP protein messenger that doesn't allow the LDL receptor uptake. So that's the normal response. And then once cholesterol gets into the cell, it's used for steroid hormone precursors to make hormones. It's used for vitamin D formation, membrane homeostasis, membrane fluidity, to insulate nerve fibers. So we got to get that cholesterol into the cells. And here you can see the lipoprotein structure. Whether it's VLDL, HDL, LDL, depends on how much density that's there from those free fatty acids and phospholipids. So you can see the apoproteins. Remember, the apoprotein B is involved with LDL, takes it from the liver out to the tissues. Apoprotein A is what's used to bind to free-floating cholesterol and bring it back in. And then this combination of like this triglyceride, cholesterol core, and these proteins that are used for transport. Here you can see chylomicrons. These are what we ingest and bile helps produce, mixing with our fats for digestion. The liver makes VLDL, and as it translates into circulation, fatty acids and phospholipids are dropped off. Eventually becomes LDL. LDL binds to the receptor. Some of this LDL remnant is circulating, is free cholesterol circulating around. ApoE protein binds, so that's HDL. And here you can see again VLDL, different sizes, IDL, and then you can see LDL has different sizes as well. And this is where the particle size comes in. Now remember, if the vascular epithelium is injured and there's a leaky vascular epithelium, smaller LDLs can then come in, and then these smaller LDLs get trapped. That's why there's an increased risk for the smaller LDL size. But the size of the LDL doesn't matter if you don't have vascular injury, if you don't have vascular permeability. So that's the key thing there. And then HDL has different sizes too. Obviously, the larger the HDL, the more cholesterol it can bind to and take back to the liver, and so forth. These are just some of the protein messengers. Don't forget ApoE. ApoE is something that's involved with Alzheimer's disease development. The transport protein that can turn on beta amyloid pathways. But as far as heart disease goes, the key thing is to remember that the ApoB is used for LDL, and the ApoA is used for HDL, right? And then here you can see roles of ApoE and ApoB, because this is something that you can measure in the lab as an indicator for heart disease. And ApoB is this from the liver out, and ApoA1, specifically A1, is where this binds to HDL and brings cholesterol back to the liver. Just the diagram of everything put together is like the other one. You ingest dietary fats, you get chylomicrons, you get some fat tissue breakdown, you get these apoproteins that transport it to the liver, LDL goes out, VLDL goes out, VLDL becomes IDL, then LDL, LDL binds to a tissue, the remnant cholesterol binds to A1, apoproteins, because it becomes HDL and goes back to the liver. Here's another illustration of that here. Cholesterol makes VLDL. VLDL starts to have phospholipids and triglycerides break off, eventually becomes LDL. LDL can go into the tissue receptor, have an effect, or it can be oxidized, and so forth. And this is just another illustration of LDL binding to an LDL receptor being used for cholesterol synthesis, or LDL not responding. Some genetic familial hypercholesterol disorders. So there are some people where cholesterol does really, really, really matter and increase risk. And those are hyperlipoproteinemias. If you ever see a really high cholesterol, like in the 400 range or even above 300 range, you should do what's called a lipid electrophoresis test, a lipid phenotype test. And that'll look for these hyperlipoproteinemias. And you can see if they have these LDL receptor defects, and they definitely have increased risk for cholesterol, and you definitely need to get their cholesterol levels down. So this is normal cholesterol metabolism, function, and transport. So let's talk about what happens in the atherosclerotic processing when things go wrong, right? So hopefully by now you remember all of this only matters when this endothelium cell is injured. And when these endothelial cells are injured by many variations, that then sets up the stage for atherosclerosis development. So let me show you a video illustration of what's happening here. Here you can see the vascular endothelial cells, and you can see it's permeable. It's the first thing. So something injured the vascular endothelial cells. So the vascular endothelial cells are injured. Here's another illustration here. They're being injured. And then you get LDL, for example, smaller LDL that can get into these areas here. And the smaller LDL gets trapped in here, especially gets trapped when free radicals oxidize it, becomes oxidized LDL now. It can't bind to any receptors, has a hard time leaving. Macrophages, then monocytes come in, they turn to macrophages, they engulf the oxidized LDL, and they convert them into something called a foam cell. These foam cells are involved with what we call an atheroma, and then you get platelets that start to stick together to this atheroma. You get a thrombus, and if this thrombus breaks off, you get an embolus, and the embolus then can embolus can get into bloodstream and then clog up and cause a clot, and then you get an embolytic, for example, stroke. So that's the mechanism. So here you see endothelial cell destruction. Then you get it. So if something injures, let's go through the steps again in a different diagram. Endothelial cell injury, endothelial permeability, endothelial dysfunctions when all the symptoms of low nitric oxide come in. Then you start to get an arterial plaque from those foam cells, which are those ingested oxidized LDL by macrophages. And then those foam cells start to cause platelet hyperactivity. Then you get a thrombus formation, and the thrombus formation increases the size of the atheroma, so you get greater clogging, and it can even break off and be an emboli. So it all comes down to injury of the endothelial cells. Once that takes place, then everything else matters. So when you look at these epithelial cells, you have injury. So let's talk about this first. So when you look at this vicious cycle, these are the most common things that can injure these endothelial cells. We'll talk epithelial cells or endothelial cells, right? Epithelium is a location, endothelial cells specifically. Increased blood pressure, increased homocysteine, pathogens, free radicals, and TMAO. They come in and injure these cells. Then you get vascular permeability. And if you have things where you have more pollutants, infections, dietary antigen toxins that increase free radicals, then you have antioxidant reserves in nitric oxide and flavonoids and dietary antioxidants and things that increase NRF2 or nitric oxide, you get injury to the vascular wall. So injury to the vascular wall then causes permeability, right? So now you have this vascular permeability, and then cholesterol, especially smaller size cholesterol, gets through these leaky permeable cells, and then it starts to accumulate. So you can see diagram, smaller LDL is higher risk because it can get inside and then it gets trapped. Then once it gets trapped inside here, then free radicals are also involved to get oxidized. So cholesterol accumulation in the vascular wall takes place. There's oxidation of these LDL particles now. So they're trapped. They're even trapped before oxidation, but once they become oxidated, they get larger. Their structure changes, so it's very hard for them to leave. And then here you see this oxidation of trapped LDL. So LDL particles across the permeable endothelium can become oxidized and trapped in the cell wall due to structural change. You can see LDL coming in. Smaller sizes, obviously, you're going to get in much easier than larger sizes. Free radicals come in, change the LDL, oxidize the LDL. This oxidized LDL then creates a whole series of inflammatory reactions we're going to go over in a second. And the more free radicals is in the system, the more inflammation is in the system, the greater risk there is for oxidation of LDL and atherogenesis and so forth. So here's the step-by-step approach of what's happening with these trapped particles. So is injured permeable of vascular endothelium, circulating LDL becomes trapped within the vascular endothelium. That if you have more number of lipid particles or greater small lipid particles or greater blood pressure to push lipids in, then you get greater cholesterol diffusion across the endothelium that's permeable. Once these get in there, these lipid particles get trapped. And once they're trapped in there, there's inflammation within that vascular wall. They get oxidized and that LDL changes shapes. That's all that's happening here. So remember, blood pressure also pushes these in, high blood pressure. And then this oxidized LDL, you can see change structure. They become modified, glycated or oxidized. Their structure changes. And then once they become oxidized LDL, there are receptors that can bind to them that are very inflammatory. And these oxidized LDL pathways start to have effects on platelets, endothelial cells, smooth muscles, macrophages, and neutrophils, to the point where these oxidized LDLs bring in circulating platelets and bring in circulating monocytes to convert into macrophages. And then these oxidized LDL particles that signal platelets to come in and signal monocytes to come in to migrate in, which then mature into macrophages, start engulfing these oxidized LDLs. And then these oxidized macrophages, these macrophages that have now consumed oxidized LDL, start to plaque together and move together, and this becomes a formation of a plaque. So the macrophage will ultimately transform into lipid-laden foam cells and prototypical cells in the atherosclerotic plaque. And foam cells are basically macrophages that engulf and ingest oxidized LDL, and their structure changes. Here you can see oxidized LDL binds to LOX1 receptors on macrophages initiates macrophage migration, inflammation, and foam cells that lead to arterial wall plaquing. So these oxidized LDLs bind to these macrophage LOX1 receptors. They get incorporated into the macrophage. They create inflammatory responses. Foam cells start to develop. And then these foam cells then create their own signaling molecules, changes smooth muscles, causes inflammation, causes further oxidation. And then you start to get these foam cells that start to core together. Platelets start to come in, top of these foam cells, these plaques. Then you get thrombus formation. And then you can see it. You can see the foam cell formation. You can see cadaver arteries. You can see these foam cells called lipid-laden macrophages as our type of cell that contains cholesterol. They form plaque that can lead to atherosclerosis. You can see those changes there. And this is the whole process here. So permeability, injury to the endothelium, HDL crosses, LDL gets oxidized, oxidized LDL gets taken up, would create signals to bring in monocytes and platelets. Macrophage monocytes come in, they get recruited in, they mature into a macrophage, macrophages engulf the oxidized LDL. This then creates its own inflammatory messengers. You start to get the atheroma development, then you get platelets, and then these platelets lead to fibrosis. So here's the mechanism, a different illustration as we work through this. High blood pressure, high homocysteine, high pathogens, free radicals, TMAO. They cause injury to the epithelial cells. You get vascular permeability, cholesterol accumulates in the vascular wall. You get oxidation of trapped LDL. Platelets aggregate to the injured cell wall. These platelets that aggregate to the cell wall become thrombus. So then you get thrombus formation. And then this thrombus formation can decrease the space, become unstable or stable. Can either break off or not break off. Stable thrombuses just increase the space occupying area, and unstable thrombuses break off and can become emboli. And then the thrombus formation narrows the artery, as you see here, occlusive thrombus. And then as the artery gets narrowed, that'll increase blood pressure. That'll then cause narrowing of the arteries, of the coronary arteries that can lead to heart attacks. It can narrow the arteries that then increase pressure in the arteries that then lead to bursting of the arteries, hemorrhagic stroke. Or they narrow the arteries in which the pressure in the arteries and the distal small vessels start to rupture, called microvascular disease. Or the narrowing arteries of the arteries in the legs get occluded. There's not enough blood flow to the feet and lower limbs, and you get peripheral arterial disease. Or this thrombus formation becomes an emboli. And this emboli then breaks off. And if the emboli breaks off, it can lead to an embolytic stroke. It can also break off and go into a smaller coronary artery, cause myocardial infarction, where the emboli can get into the venal system, cause venous obstruction, cause deep vein thrombosis. And eventually that deep vein thrombosis in the legs can then go up the femoral vein into the heart and into the pulmonary tree, and then cause a pulmonary embolism. So those are the mechanisms. So when you look at it this way, it's like, oh, that's so easy. This makes sense. Okay, now we'll talk about TMAO a little bit later. We'll talk about some of the other things a little bit later, but here's the basic question. How does a person get a heart attack or have a stroke with normal blood pressure and normal cholesterol? Because it's not the only marker. Because you could have someone that has normal cholesterol, normal blood pressure, that is something that's increasing injury to the epithelium, like a chronic pathogen, like chronic viruses, like H. pylori. Think of H. pylori. H. pylori is to the vascular endothelium what hepatitis C is to the liver. Hepatitis C destroys the liver. H. pylori goes in and destroys the vascular endothelium. So you can have someone who has an H. pylori infection. They're around chemicals. Maybe they work in a lab, right? Maybe they're scientists. Who knows what? Maybe they live right next to a gas station. Get free radicals exposure all the time, right? Maybe they have deficiency of vitamin E. Even though their blood pressure is normal, the cholesterol is normal. They've had injury to the epithelium. They have oxidation, they have platelet aggregation, and that sets up the stage for everything else. You don't need to have high cholesterol. You need to have high blood pressure. Those are just things that feed into the system. So remember, 50% of people have a heart attack with normal cholesterol. These other mechanisms are involved. And this is why we got to look at other markers when we do a cardiovascular workup. Now, hypertension obviously is going to feed into all these, right? So when you look at these mechanisms, um, hypertension can cause further injury to the epithelial cells by mechanical force. Hypertension can push the tight junctions apart and actually push lipid particles into the permeable barrier and cause more trapping. Hypertension can push a thrombus to become an emboli and push the emboli into tissue. So hypertension feeds this whole pathway. Free radicals, toxic chemicals, free radicals from glycosylated hemoglobin, they can cause more injury to the epithelial cells. We have decreased nitric oxide, decreased vascular growth factor, and decreased angiogenesis. Free radicals can cause permeability. Free radicals can oxidize LDL. Free radicals can increase the thrombus formation, whether it becomes stable or unstable. But this is where free radicals come in. Trans fats from processed fats, they can injure the epithelial cells. They cause permeability. They cause oxidation. They can cause thrombosis. Insulin surges from not controlling blood sugar levels. They increase blood pressure. They can cause cholesterol accumulation in the cell wall by oxidizing LDL. They can cause platelet hyperactivity. We'll go into those mechanisms in a little bit more detail. And then systemic inflammation feeds these. So you can see some of these things can be fed by various mechanisms. So this is the step-by-step approach of how we develop atherosclerosis. And these are the triggering events and things that feed into them. Now, let me just start with this one here. So ultimately, so what do you do with this? It's really cool, nice diagrams, but I had a patient in front of me. Yeah, I understand. We're going to get there, okay? The first thing is injury to the epithelial cells. You get symptoms of low nitric oxide. That's number one. This is when they come in, low muscle endurance, low brain endurance, low sexual stamina, poor circulation, elevations in blood pressure. But we should also put blood pressure just rising, because you have lots of people that have low blood pressure. And they go, oh, my blood pressure is better now. It's not better. And it means that there's more endothelial dysfunction, right? I mean, depends how you look at it. Delayed tissue recovery, erectile dysfunction, sexual arousal disorder. So you need nitric oxide to have stimulating effects on the clitoris in women in order for them to have an orgasm. So one of the things that happens with men when their nitric oxide levels are low, they have erectile dysfunction. But in females, they get what's called sexual arousal disorder, where they just don't have the orgasm, which then makes them disinterested in sex. So nitric oxide pathways impact males and females differently when they're low. So these are all from the medical history, okay? Then these early signs of this pathway get expressed into examination findings: cold hands, cold feet, white nail beds, right? Pallor nail beds, reduced capillary refill time, blood pressure. We're going to go into these in much more detail. I just want to give you a few for this diagram. And then if you look at each of these pathways, we have labs. And these are all the things we can measure that measure different steps, right? So for things that cause injury to the epithelium, we can look at CRP, homocysteine, ferritin, pathogen antibodies, ones that will go over that are specific to causing injury to the epithelium. Serum heavy metals, what's actually in the bloodstream. Serum heavy metals reflect what's actually in the bloodstream, not in tissues. TMAO, which is a gut metabolite that happens when there's different changes that take place in the microbiome. These all cause injury. So this is what we're looking at when we do a lab test for these markers. All the green are lab markers. Then if you look at total cholesterol, LDL, VLDL, HDI, LDL, lipoprotein particle size, apolipoproteins like AB, AB1, you're looking at this cholesterol transport mechanism. And then you can measure oxidized LDL. And then once you get oxidized LDL and start to develop atheromas and dislodges of emboli, that's when a protein called MMP9 goes up. So you can measure that. And then you have platelet aggregation, things like fibrinogen activity, platelets, things that impact prostaglandin levels, and fatty acid profiles. These impact these. So now we can look at all of these factors to determine what's going on. So in summary, ultimately, we look at the vascular system. It's more than just pipes. It's these endothelial cells. These endothelial cells really have their own functions. These endothelial cells are involved with functioning as an endocrine system, releasing things like vascular growth factor and things like nitric oxide. And then these help with angiogenesis and regeneration of tissue and getting blood flow so you can have recovery. The vascular endothelium is involved with healthy transport of nutrients and immune cells into heart tissue and skeletal muscle and cardiac uh, cardiac tissues, cardiac source for fuel. And then the vascular endothelium can be injured and disrupted. And then that then leads to permeability and these abnormal changes. And changing the endothelial dysfunction can impact blood pressure in combination with things that then alter the renin-angiotensin system, like stress responses, too much salt, chronic inflammation, oxidative stress, lack of potassium, lack of magnesium. And then we get this atherosclerotic process that starts from one step to the other, where you can pick up things from your medical history to physical exam to labs and determine what's happening with someone. So those are the things we're going to get into next, but this was just a section I wanted to cover on making sure you understand vascular pathophysiology. So now, if you weren't clear with how LDL and VLDL and particle size and oxidized LDL and MMP9 and TMAO and all these other variables come in, you have the background of what they're involved with destroying the vascular endothelium. And we'll make this more clinical as we go along. Thank you.